morning, everybody. Thank you for joining this morning. This morning we have Dr. Tomek Piorkowski, who is a haematopathologist working at Pascal Laboratories. He qualified in laboratory hematology in 2013 and briefly worked 2023, sorry. Thank you. And briefly worked at the South African National Blood Service before moving to Pathcare. Prior to specializing, he worked as a GP in various primary healthcare roles and also lectured part-time at the University of Pretoria. His interests include consultative hematology, laboratory quality improvement, and morphology. Thank you very much.
Thank you so much. So today's topic is Bloody Easy, a Whirlwind guide to blood products. And the origin of this presentation is that while I was working at Sanbus, I was approached by some registrars who basically wanted a sort of crash course presentation in transfusion medicine. So this is this presentation, I'm basically going to touch on must-know facts with regards to blood transfusion. So hopefully it'll be a nice introduction for some of the listeners and a good revision for some of the more experienced listeners. Oh, my slides are not moving. All right, so briefly we're going to look at triggers for transfusion, how to administer the products, transfusion reactions, and we'll touch a bit on blood donation. First product we're going to discuss is red cell concentrate. And to start off with, when would you give red cell concentrate? What would be your transfusion trigger? You can divide it between the non-bleeding patient and the bleeding patient. And the best sort of evidence-based guidelines suggest that if your patient is not bleeding, for the vast majority of patients, even if it's the ill patients, you don't need to transfuse until your HB is 7 or less grams per deciliter. There are certain categories where the evidence is not as strong for the 7 gram per deciliter cutoff, but there is evidence that an 8 gram per deciliter cutoff should be a safe cutoff to use for patients about to go to orthopedic surgery, cardiac surgery, or pre-existing cardiovascular disease. So in essence, they're saying the patient is not bleeding. The evidence shows that there's no benefit to transfusing patients above these cutoffs. So because of this sort of 7 to 8 range, some hematologists in Frankfurt in 2018 sort of took a middle road and said for patients undergoing cardiovascular surgery, you can use a threshold of 7.5 grams per deciliter. And even if the HB is less than 7, if a patient has clear nutritional deficiencies such as iron deficiency, B12 deficiency, and folate deficiency, these patients often respond spectacularly well to aggressive nutritional supplementation. So even if the HB is less than 7, you should consider first aggressive nutritional supplementation. Watch if they have a brisk reticulocyte response, and often they'll feel much better, and you can avoid giving them a blood transfusion. Sickle cell disease is a little bit of a different scenario. So 2 things to note about sickle cell disease. You should never transfuse a sickle cell patient to an HB above 10 grams per deciliter because they can develop a complication called hyperviscosity. And the transfusion threshold in sickle cell disease is not as well defined as in other population groups, with some centers using transfusion thresholds as low as 5 grams per deciliter based on expert opinion, that these patients tend to be very well compensated to chronic anemia and do not actually do that well if you over-transfuse them. Okay, so those are non-bleeding patients. But with bleeding patients, you need to think a little bit differently, and the goal is to maintain an HB above 7 grams per deciliter while they are bleeding. So you basically decide how much blood I need to give to try and keep this patient above 7. In the 2018 Frankfurt consensus, they did decide that for GIT bleeding, you should be careful of over-transfusing. Keep the HB between 7 to 8 grams per deciliter for GIT bleeding, as the evidence shows that if you push the HB above 8, you actually have worse outcomes because you actually promote GIT bleeding of too high HB and too much blood. Those are adult cutoffs. For neonates, it's a little bit different, and we divide the neonates in terms of how old they are and whether they need respiratory support or not. And you'll find that there are actually very various transfusion guidelines for neonates. It's not very well standardized. So these are the British guidelines. But if you look at other guidelines, you might find that the transfusion triggers are a little bit different. But with neonates, if they need respiratory support, transfusion triggers are a bit higher. The younger they are, and if they don't need respiratory support, transfusion triggers are a little bit lower, going down to adult level by 3 weeks on a non-bleeding neonate. Okay, so if you've reached a transfusion trigger, or if the patient is bleeding and you need to give the HB up, how would you think about the dosing of the red cells? Most pediatric dosing of blood products is 10 mils per kg for almost all products. So 10 mils per kg of red cells for a pediatric dose will increase the HB by about 1 gram per deciliter. For an adult, now there's someone that's about 70 kilograms. 1 unit of red cell concentrate will generally push the HB up by 1 to 2 grams per deciliter. Now, if your patient is not bleeding and your patient is stable, the scientific evidence shows that giving 1 unit at a time is much better than pumping 2 units at a time. You should give 1 unit at a time, then reassess the clinical condition and the need for transfusion at the end of each transfusion. And the rationale for that is that when you give 1 unit at a time, you have much less risk of a transfusion-associated adverse event. Your risk of adverse events is increased if you're putting in 2 or more red blood cell units in succession. And the specific complications associated with 2 units or more at the time transfusion, such as an increased risk of pulmonary edema and also transfusion-associated circulatory overload, especially in high-risk patients that are elderly, female, and patients with heart or kidney failure or positive fluid balance. Furthermore, clinical outcomes are generally not affected by 1 unit dosing in the non-bleeding and stable patient. In other words, you're not going to have worse outcomes by giving 1 unit, waiting a few hours or even a day to give the second unit. Patient outcomes are in fact the same. So single unit dosing has been proven safe, and it's been proven safe when applied with a restrictive transfusion trigger being 7 to 8 grams per deciliter. And that's been done in a number of randomized controlled trials. There are also some public health benefits, such as conserving blood supply for other patients, and it conserves financial resources. And the evidence summarizing single unit transfusion is on the International Society of Blood Transfusion website. They have a webpage dedicated to all the articles that show that single unit dosing with restrictive triggers is the way to go in current modern transfusion medicine practice. Again, for the non-bleeding and stable patient. So this is a nice poster for Canadian blood transfusion, because the Canadians used to give 2 units at a time as standard practice, and they were trying to change that behavior. And they came up with the phrase, "Why give 2 when 1 will do?" Which I thought is a nice phrase to share. But in summary, the evidence shows don't transfuse more than 1 red cell unit at a time for a patient that's not bleeding. Don't transfuse red blood cells in asymptomatic non-bleeding patients with an HB of more than 7. And don't transfuse blood if nutritional therapies could be as effective. Next blood product we're going to discuss is platelets. And again, we can divide it into the non-bleeding and the bleeding patient. You're always justified in giving platelets if the platelet count is less than 10 and you're worried about a spontaneous bleed, but please don't treat the FBC, you must treat the patient. So if you have a patient with chronic aplastic anemia, they're stable, they live near the hospital, they have their cyclocapron in the medicine cupboard, it's not necessary to give them platelet transfusions just to treat the FBC count. On the other hand, if you have a patient who's on chemotherapy, they're about to get the next round of chemo, HB is already 6, that is a good patient for a platelet transfusion, because that platelet count is going to drop even further with the chemo. So you need to treat the clinical context of the patient. Then the other platelet cutoffs, if it's less than 20, you should transfuse if you're going to do a procedure that's not associated with significant blood loss, such as you want to put up a CVP. On the other hand, if the platelet count is more than 20, you can probably put something like a chest drain or central line without needing platelet. If If you have a patient on anticoagulants and the platelet count is dropped below 30 and you can't stop the warfarin or the DOAC, they are at very high risk of spontaneous bleeding, and you are justified in transfusing the platelet count above 30. If you're going to do a lumbar puncture or epidural anesthesia, you need a platelet count of at least 50. That is quite variable depending on which society guidelines you read. So there's a little warning box. Please correlate the recommendations with appropriate society guidelines. So I think the Swedes are happy to do an epidural anesthetic of a platelet count of 50. The Americans use a platelet cutoff of 75. The British use a platelet cutoff of 80. None of these are very well based in terms of scientific evidence. They're expert guidelines. So definitely below 50 if you're going to do an epidural and to get platelets. But what the correct cutoff is, you'll need to decide what is the appropriate guidance for your situation. If you're going to do a procedure of major blood loss, major surgery or with lots of blood loss, more than 500 mils, you need to keep the platelet count above 50. And generally, anything that involves the central nervous system requires a platelet count of above 100 to maintain hemostasis. With neonates, cutoffs are a little bit different. So you're justified in transfusing platelets in a term infant with a platelet count less than 20 if you want to prevent a spontaneous bleed. Slightly higher cutoffs for the preterm neonate or someone with neonatal albumin thrombocytopenia. And if they're very young and preterm, if they're about to go for neuraxial surgery, or they're about to go for surgery, or they have concurrent coagulopathies or high risk of hemorrhage, keep the platelet count above 50. And as with adults, if they're going for neuraxial surgery, you need a platelet count of more than 100. For acute bleeding, you give platelets for severe bleeding of WHO grade 2 or above. And to summarize what that means, WHO grade 2 essentially means any bleeding that you as a clinician think is important. So if a patient's got severe bleeding and casualties and the platelet count is less than 50, you want to maintain the platelet count above 50. But if they have multiple trauma or injury to the central nervous system, you'd actually want a higher platelet count of more than 100 to maintain hemostasis. In between 30 to 50 is a sort of gray zone. If the bleeding is not too severe or life-threatening, and the platelet counts between 30 to 50, you might be able to achieve hemostasis by giving, say, tranexamic acid or just applying pressure for an epistaxis. So you can hold off on immediately ordering platelets. You can try an alternative therapy because usually 30 is enough to achieve hemostasis. So if it's not too, you're not expecting a patient to decompensate very rapidly, between 30 and 50, you are allowed to try something else before ordering the platelets. The big exception is for patients known to have a platelet dysfunction disorder, such as Glasmann's thrombocythemia. These patients, they can have a normal platelet count, but their platelets are dysfunctional, so that you can't actually treat according to a platelet count. You need to treat for the clinical response. So you can give them platelets even if their platelet count is normal, because those platelets don't actually function anyway. How would you dose platelets? So one therapeutic dose of platelets, so one adult dose should increase the patient's platelet count by about 35 to 45 times 10 to the power of 9 within 10 to 60 minutes post-transfusion. If the patient's less than 15 kilograms, you need to use pediatric dosing, which is 10 mils per kg. You can go up to 20 mils per kg. The next product I want to discuss is fresh frozen plasma. When would you give fresh frozen plasma? So you can give fresh frozen plasma when the INR is 1.8 or greater for patients who are bleeding or prior to an event that will actually cause a lot of bleeding. And there's a multiple coagulation factor deficiency. Or alternatively, you have a patient with no coagulative factor deficiency, but you don't have an alternative. So perhaps a hemophilia patient and you don't have any factor 8 or factor 9 available, then you can technically give fresh frozen plasma instead. Bearing in mind that patients with liver disease, your INR level becomes unreliable in terms of predicting bleeding. And often patients with severe liver disease do not actually need correction of an INR abnormality before procedure. You can also give it in the absence of an INR if you activate on a massive hemorrhage protocol. and the patient's clinical status is so bad that you feel that it's better to rather give the FFP before waiting for the INR. So that is a justifiable reason. And also another indication to give FFP is thrombotic thrombocytopenic purpura. So then you wouldn't care about the INR because the mechanism of correction is different. Briefly, I mentioned the massive transfusion protocol. So most massive transfusion protocols published in the West use a 4:1 ratio, which took me a while to figure out exactly why they used a 4:1 ratio. But when I read about how blood products are produced in Western nations, it then made sense why they use a 4:1 ratio. So in countries like Canada and US and Europe, they will take a unit of whole blood from a donor. They'll centrifuge it into 3 layers of plasma, buffy coat, and red blood cells. Buffy coat consists of a mixture of white cells and platelets. Then they'll take 4 of these sort of buffy coats to make a pooled platelet unit mixed with plasma or platelet additive solution. And if you ideally you would leukoreduce it to get rid of the white cells, so you have a pure platelet product. But basically, the rationale for 4:1 is that you need 4 platelet units to make 1 adult platelet unit. So this is kind of the rate limiting factor. In order to give the equivalent of 4 donor platelets, you give 1 big unit, and then you give 4 red cells and 4 plasma units to match the 4 platelet buffy coats. So it's actually 4:4:4, meaning for every 1 donor buffy coat, you're giving 1 unit of red cells and 1 unit of plasma. So that's why the 4:1 ratio is quite common. That's not quite how we produce blood in South Africa. In South Africa, we use 5 platelet buffy coats, so it's debatable how appropriate this ratio is in the South African context, but also debatable how strictly we have to apply this ratio, as different some other ratios have been shown to be reasonably effective as well. But that's the rationale of the 4:1. The dose of plasma, 10 mils per kg, will increase factor levels by about 15%. For TTP, a dose is 30 mils per kg daily. If you do not have plasma exchange immediately available, you can give it as an IV infusion in divided doses of 10 mils per kg TDS until you get the plasma exchange. Problem with this therapy is that fluid overload quickly becomes problematic, and you also don't remove the ADAMTS inhibitors that are part of the pathogenesis for TTP. But this does have, giving an IV infusion of FFP does improve survival outcomes, although it's not as good as plasma exchange. Main reason being that the patients don't tolerate the fluid overload very well. All right, the other product you can order from Sanbus is cryoprecipitate. And basically, fresh frozen plasma can be thawed to generate something called cryoprecipitate. And this fluid is very rich in factor VIII, von Willebrand factor, and fibrinogen. It was traditionally used for hemophilia A, but factor VIII concentrate has replaced cryoprecipitate for that indication. And cryoprecipitate is likely to be replaced eventually by recombinant or fractionated forms of these products. You can now in the US get von Willebrand factor concentrate and recombinant von Willebrand factor, and also recombinant fibrinogen. So once those products are available in South Africa, the indications for cryoprecipitate will be reduced. But for now, the main indication of cryoprecipitate is to treat hyperfibrinogenemia, defined as less than 1 gram per liter of fibrinogen, and also for dysfibrinogenemia, when you have normal levels of fibrinogen, but they are dysfunctional. It's also been described as effective treatment for factor 13 deficiency, and it has been suggested for use as second-line therapy for patients who cannot receive platelets for whatever reason, and they are bleeding. The dose of cryoprecipitate is 1 unit for every 10 kgs, and that will raise your fibrinogen by 1 gram per liter. The other product to discuss is cryopoor plasma. Cryopoor plasma is the waste product left over from precipitate production. It is rich in ADAMTS13, and currently the only indication for cryopoor plasma is the treatment of thrombotic thrombocytopenic purpura, or TTP. which can be caused by either deficiency or inhibition of the ADAMTS13 enzyme. It's usually given by plasma exchange, and it is cheaper than fresh frozen plasma. So if you are trying to save the patient's funds, you can specify when you order the plasma exchange for TTP that you specifically want to use cryopoor plasma for the treatment of TTP. Studies have shown that cryopoor plasma is equivalent in efficacy to fresh frozen plasma. So you're going to get the same effect at a cheaper price. So just to show you some of the prices here. For fresh frozen plasma, it's 1,600. Oh, sorry, that's cryo. For fresh frozen plasma, it's 2,000 rand, but and the cryopoor plasma is 400 rand cheap. So you are going to save a little bit of money. That said, this product is also likely to be replaced in the near future. There is a recombinant ADAMTS13 enzyme that has been now available in the US market. Once that becomes available in South Africa, rather than treating the patient with blood products, we can actually then treat the patient with ADAMTS13 enzyme and then even do plasma exchange using albumin. To just flush out the inhibitors, which will be much cheaper and potentially as effective. You can also order whole blood from the South African National Blood Service, and the South African context is almost exclusively used for whole blood exchange for neonates. And the way SANBIS makes whole blood is they use low antibody titer O-neg whole blood from donors, which is different from how it's done in more well-resourced settings. In more well-resourced settings, they artificially sort of make whole blood, manufacture whole blood by mixing AB plasma with O-neg red cell units, which theoretically should be a slightly safer product. There are platelets in the SANBIS whole blood product, and they have a very short half-life as they're already pre-activated because they are kept in the fridge. So the moment you put a platelet product in the fridge, it activates the platelets and the half-life dramatically shortens. Indications for whole blood would be exchange transfusion for neonates, so usually for hemolytic disease of the newborn. And it is technically indicated for massive transfusion because the platelets are already activated by being in the fridge. They are theoretically supposed to be able to be more effective at stopping immediate hemorrhage since they're already pre-activated, even though the half-life is very short. That said, it is a struggle for SANBIS to provide units for massive transfusion to keep in casualty units. There's generally a constant shortage of whole blood, so it's unlikely in our setting that you're going to have a regular supply of whole blood in your fridge in a casualty setting. If you decided to give blood, what IV access do you need? If you're resuscitating an adult, you're going to need a 16 to 18 gauge Gelco, so gray or green. But if it's a routine transfusion, you don't need a big line. You can get away with a pink or a blue line, especially for patients who are chronically transfusion dependent. I think it helps reduce the amount of fibrosis in their veins if you're using a smaller Gelco. And that's specifically for red cells and other blood products. Any size is adequate. Pediatrics, you can give a blue or yellow Gelco, and all components can also be given through a central line if that is available. Just briefly mentioning what is blood on a returnable basis. So this is not really that applicable, I think, in private, but in government, there are some hospitals which are very isolated but still do elective surgeries. So SANBIS offered this service called blood on a returnable basis, where you can order the blood prior to your elective surgery, and they'll bring it in a hamper. In a sealed hamper to the hospital. And if your elective surgery goes well and you don't need to give blood and you don't open the hamper, you can return the hamper, and then SANBIS doesn't charge those unused units. So we'll only charge sort of the cross-matching fee. That said, the blood units do need to be returned within 12 hours of issue. And if you do open the unit, and even if you only use one unit, they charge for both units. And you do have to return the empty hamper. So this is, as I said, specifically for the isolated rural hospital doing elective surgery where they're not sure if they really will need blood or not, but they can order it and then return it if unused. Right, now I want to discuss transfusion reactions. So I find this classification by symptoms to be the most intuitive way of understanding transfusion reactions. But yeah, transfusion reactions that predominantly present with fever, dyspnea, allergic reactions, hypotension, hemolysis, cytopenias, and infections. And the ones that present with fever as the main symptom after a transfusion will be your bacterial sepsis, in other words, the unit was contaminated, your acute hemolytic transfusion reactions, and your febrile non-hemolytic transfusion reactions. The ones that present primarily with dyspnea, your transfusion-related acute lung injury or TRALI, and your transfusion-associated circulatory overload, TARCO. If you've got hemolysis, you need to think of an acute or delayed hemolytic transfusion reaction. And if you start developing unexpected cytopenias after a transfusion, you need to think of graft versus host disease, post-transfusion purpura, alloimmune thrombocytopenia, and alloimmune neutropenia. So we're going to go through some of these conditions and how to approach them. So if you're called to see a patient on a transfusion who's having fever, the temperature suddenly spiked, you need to stop the transfusion, maintain your IV access with saline, do clerical checks, make sure you're giving the right products to the right person, monitor the vitals, and contact the blood bank. Because the main sort of thing to exclude here is an acute hemolytic transfusion reaction. And the only service that will be able to do that for you is the blood bank. So they will need some samples, and they will retest all the samples to see if there's an acute hemolytic transfusion reaction. If the symptoms are very serious or very high temperature, there's shock or other sort of signs and symptoms of marked toxicity, you will not restart the transfusion. You'll either consider this to be an acute hemolytic transfusion reaction or transfusion-associated sepsis. You need to contact blood banks, send them samples, do your own hemolytic workup and septic workup as well, because that will not be done by blood bank. If the symptoms are not serious and the blood bank calls you to say, listen, the blood groups are compatible, you can consider the diagnosis of febrile non-hemolytic reaction. You can give a dose of paracetamol and then restart the transfusion at a slower rate. And if the patient is asymptomatic at that point, you can carry on the transfusion. But if the symptoms recur, it's wiser to rather stop the transfusion. Now, just to note that with an acute hemolytic transfusion, there's a release of free hemoglobin and complement, and it can stimulate multiple pathways. So typically the inflammatory pathway is aggressively stimulated, so that's why they present with fever. But you can have stimulation of coagulation, allergic pathways, bradykinin pathways causing hypertension. And therefore, an acute hemolytic transfusion reaction can mimic any other transfusion reaction. In essence, every transfusion reaction is an acute hemolytic transfusion reaction until proven otherwise. Bearing in mind also the free hemoglobin and the red blood cell stroma is toxic to the renal system, so it can trigger renal failure. And if you have acute hemolytic transfusion reaction, the management for that would be intensive supportive care, the goal being to maintain your urine output by IV fluids and furosemide, and to manage DIC or bleeding as required due to stimulation of coagulative pathways that can cause a severe DIC. As a sort of Hail Mary last resort, you can consider red blood cell exchange transfusion to get rid of all the incompatible red cells. Okay, but if the patient's had a transfusion and the main symptom is breathlessness, again, you do the standard things of stopping the transfusion, maintain IV access, clerical checks, check the vitals, call blood bank, and ask them to exclude acute hemolytic transfusion reaction. While you're waiting for that, you want to monitor the SATs and order an X-ray and give oxygen, diuretics, and supportive care as required. Your differential diagnosis would be TRALI. Acute lung injury typically presents with dyspnea plus hypotension. Your transfusion-associated circulatory overload, which typically presents with dyspnea plus hypertension, and a transfusion-associated dyspnea, which is a diagnosis of exclusion, and also anaphylaxis. With TRALI, you'll have infiltrates on your chest X-ray. So if you have a hypertensive dyspneic patient with chest X-ray infiltrates, management is really just oxygen and ventilation. So it's purely supportive. even with best supportive management, the outcomes for Charlie patients tend to be quite poor. With circulatory overload, so they'll have a clear chest X-ray, but they'll look fluid overloaded, they'll be hypertensive, they need oxygen diuretics, and all future transfusions need to be given at a conservative pace, so at a slower rate and definitely 1 unit at a time. All right, now the patient has urticaria or anaphylaxis. You do exactly the same thing as usual. And if the symptoms are very serious, say very serious hypertension or the very serious dyspnea, widespread rash, you would not restart the transfusion. Treat the patient as an anaphylaxis and don't first stabilize the patient. If the symptoms are not that serious and it looks like an allergic reaction, you can give an antihistamine plus minus a steroid. And once those are sort of on board and you think that circulating in the patient, you can cautiously restart the transfusion and monitor the patient. And then you only stop the transfusion if the symptoms recur. Traditionally, allergic reactions have been associated with IgA deficiency. That is now an area of contention, saying that the evidence for IgA deficiency and association of allergic reactions is not really that strong. So some older guidelines suggest doing serum IgA levels for these patients and giving IgA deficient blood if they have IgA deficiency. But as I said, some authors are now, some experts are now saying that is completely not necessary. The evidence is simply not strong enough. Right, what if they call you to the ward because the patient's blood pressure has suddenly dropped? So if the patient has a systolic blood pressure drop of more than 30 milligrams of mercury during or within 1 hour of the transfusion, or the systolic blood pressure drops below 80, you do all the things as usual and assume it's an acute hemolytic transfusion reaction until proven otherwise. Other things that can cause a sudden drop in blood pressure, your bacterial sepsis, your febrile non-hemolytic transfusion reactions, Charlie, anaphylaxis, and the sort of diagnosis or exclusion here would be bradykinin-mediated hypertension, which typically happens on patients on ACE inhibitors. If you've excluded all the above, you can consider cautiously restarting the transfusion. Otherwise, if you made a definitive diagnosis, should not transfuse until you've sorted out the underlying issue. That was a brief guide to your transfusion reactions. I'm going to briefly discuss blood donation. Only about 1% of the South African population donates blood, which is much less than in other Western countries. And considering the high need for blood products in South Africa, which is above average compared to the more developed countries, this is actually not enough to maintain a regular blood supply to the South African population. So I do encourage everyone to donate blood. You can donate blood if you are between the ages of 16 and 75. If it's the first time donating blood, you need to be a minimum of 50 kgs and be in good health and have a low risk lifestyle. You can only donate blood every 56 days unless you decide to become a platelet donor. And then you can donate platelets every 14 days. You need to be otherwise in good health, with good HB, good blood pressure, good pulse. There are different categories of blood donors stratified by SANBIS based on the risk of causing a transfusion-transmitted infection from donor to patient. So a first-time donor or a patient or a donor who only donates more than every 24 months are considered high-risk donors for potential transmission of infections such as HIV or hepatitis. So these donors they'll harvest the plasma but freeze it and administer a quarantine plasma, and that plasma will be kept for up to a year in a freezer and will only be released if the donor comes back within that year and is found on retesting to not have transfusion, to have the infections that SANBIS screens for. They can also give plasma for fractionation, because the fractionation to generate, say, factor 8 and factor 9 is supposed to inactivate pathogens. And they do use the red cells from these donors if there's infectious disease screen is negative, but they'll not be given for emergency use and not for children. They'll be basically kept at the back of the red blood cell fridge and released for adults only if there's no other red cell product available. Next category is category R. So these are donors that are given at least 2 to 3 collections in the previous 24-month period, and they've been found to have a much lower risk of carrying an infection. So they can donate platelets via apheresis. So they can donate platelets every 2 weeks. You can when hooked to an apheresis machine. They can give donor retested plasma, meaning basically that their last donation of plasma is going to be released out of quarantine. They can give plasma for fractionation, and they can the wider range of red cell products that can be manufactured, including the irradiated and the filtered products. And then the best sort of category of donors is the category C, who are donating at least 4 months in a 2-year, or 4 times in a 2-year period. And statistically, these donors have exceptionally low risk of carrying HIV or hepatitis or syphilis or any other transfusion transmittable infection. So Sanbus makes pediatric products out of these donors, and they'll also harvest the platelets from the whole blood unit to put them into pooled platelet products. And then every other product can also be made from category C. So they only really start harvesting your platelets once you for pooled platelet products once you're in a category C. That's it for my presentation. So that's, as I said, it's a whirlwind tour through transfusion medicine on things that I think are important to know as someone who prescribes blood products. If you're a person who prescribes blood products on a regular basis, I hope this was a nice introduction to the topic or a nice refresher course. So thank you for your attention, and you're welcome to contact me. Those are my details. But otherwise, I'm open now to questions and comments.
Thank you. I think it's a topic that many doctors will find useful, and that we all assume we know already, but need to be reminded on a regular basis.
I think actually you're right. It's actually a cost, because actually if you won't be able to get one holistic kind of approach to blood products and also transfusion as a kind of single topic. So this, I mean, you summarize everything well in more details actually. And you could look at the blood products, include the complications, everything. I mean, you actually exhaust everything about transfusion products. And I think people who actually listen to podcasts, they should function as well and make clear decision as a blood transfusion is concerned. My question is just basically, I mean, you have mentioned quite a few of in terms of the sepsis. And I think in the context of South Africa, is that I remember very well during my practice as a physician, we have quite a few incidents where a few patients had a bit of cross kind of infections post-transfusion. And there was always the risk of HIV, there's a risk of CMV, and then other viruses. What are the statistics in South Africa? Are we having, those infections with the transfusion-related infection? Is it a very high percentage? Or is it less?
I don't have the statistics at my fingertips. What I can say is that since Sanbus introduced, and the Western Cape Blood Service introduced molecular testing for HIV, hepatitis, those transfusion risks have dramatically dropped, because the window period for those for HIV is now 5 days. And for hepatitis C, it's 2 weeks using molecular testing. So it's dramatically reduced the window period. There are still occasional, when I was at Sanbus, there were 1 or 2 cases that it did happen. And that speaks to just the shortage of blood products in the country. Like because our donor pool is so limited, sometimes we have to give one of those category products to a patient, and then when that donor comes back, it turns out that that donor has now transformed it to HIV. And then Sanbus has a very strong look-back program where if a donor comes back and they've developed an infection, they will then they are able to track every single unit given to every single patient. So they will hunt down the patients and try and find if there was a transfusion-transmitted infection. If you do suspect your patient had a transfusion-transmitted infection, you call your blood bank, and they will activate a look-back program. They will call the donor. They will test the donor for free to see what infections they are, and see if that. And they will also do viral genotyping on the donor and the patient at their cost to see if that was the virus that was transmitted from donor to patient. Because sometimes you'll have a patient who got transfused, they got HIV, they claim that it was from the transfusion. You find that none of the donors had HIV, or maybe one donor did have HIV, and they'll do viral genotyping. They'll find that the HIV virus in that donor was not the same one as the one in the patient, and then they exclude a transfusion-transmitted infection. So it does, fortunately, these things do occasionally happen, from what I understood at my time at SANBIS, but there are very strong mechanisms in place to try and prevent it. And it's also about conserving blood stocks. There's still a strong culture of giving 2 units at a time, giving blood to patients that probably can get away without being given blood. So that's also part of the challenge, also making sure you're giving blood appropriately to conserve blood stocks and not put your own patient at risk. So as I said, I don't have the exact statistics. I believe they are very low, but you would have to perhaps contact your local blood bank. And SANBIS does have hospital liaison officers, that's equivalent of a pharmaceutical rep. So if the blood bank doesn't have the statistics, you can ask them to put you in touch with the local hospital liaison officer, and the hospital liaison officer or SANBIS rep can give you all your statistics, all the statistics that you request from the SANBIS side, if you're interested in those statistics.
And lastly, question of, I think 3 years ago, there used to be quite a lot of hype about filters and the blood transfusion in ICU and all that. Any intake on that?
Sure. So the bedside filters are considered to be very unreliable. The other issue is by the time your blood product is at the bedside, most of the white cells have undergone apoptosis, and they will not be trapped by the filter. You actually need to filter a very fresh product. So SANBIS does filter some of its products. It needs to be filtered quite quickly before the white cells undergo apoptosis. So you can filter the platelet product and the red cell product. They're called the leukodepleted products. They are associated with much less risk of transfusion reactions, in particular CMV transmission, as well as your non-hemolytic febrile transfusion reactions. They are considered safer, and in Western settings, they leukodeplete all their products because it's just safer. SANBIS took the decision not to leukodeplete all of its products because the filters are a bit pricey and does add to the final product cost. So you, as a clinician, have a choice of giving a non-leukodepleted product that's cheaper, or a leukodepleted product that's about 1,500 Rand more expensive but safer for the patient. So that they've kind of decided that's the clinician's job to decide whether to give leukodepleted or non-leukodepleted. If you have a patient who's chronically transfusion dependent, it's safer to give them leukodepleted product because it's also a lower risk of HLA alloimmunization if you give the leukodepleted product.
Now, I've run into this now a couple of times where you have patients with polycythemia due to obstructive sleep apnea or whatever, and you send them for venous section. And I've had patients where they go for blood transfusion or for blood donation, but they say they're not allowed to. Is that true or not? Can they actually, if you are polycythemic, can you donate blood?
Would have to ask my colleagues at SANBIS just to go through the book. There's a thick book at SANBIS of every single condition and whether that patient can donate or not. And I think sometimes it's not necessarily about the quality of the blood, but about whether the patient would be able to tolerate the donation effectively.
It's not. I mean, that's not it. You basically want to every 3 or 4 months. You want to.
But basically, yes. As a general rule of thumb, if you only need to donate blood every 56 days, you should actually be. Most people will be able to donate blood. So, for example, the hereditary hemochromatosis patients, once they're at the point where they only need to be venesected every 56 days, they can switch over to becoming blood donors. I don't know about polycythemia per se, but we would have to speak to one of the doctors at SANBIS and just see what their latest guidance is.
I think you're really right, Cornell. The issue that I think we have previous discussion with some regarding actually, because yes, we see quite as a pulmonologist, we see a lot of COPD patient with secondary polycythemia. And ideally, and also the same thing as I say, those with the hemochromatosis. For whatever reason, and normally because for you to donate blood, we have to get the form from Chambers, say we needed the patient come up in a section. And then the patient was said, no, their bloods would not be used, but will be discarded. And the question that initially my thinking was, so was it more to do with the indication of hemochromatosis? Is it because the patient having certain kind of cytokines that might interfere with the blood recipient? That might, so I don't know what, but I think it's something that maybe we need to kind of do a proper research on it and then maybe update on our talks next time to see why not exactly and the reasons.
The thing is, I mean, Sambas does have a donor medical manager. And you can approach the donor medical manager saying that you would like to motivate for this patient to be allowed to be a blood donor. Here's your evidence. Would Sambas be willing to change the criteria? The criteria are not set in stone. It's just that Sambas is perpetually understaffed. So the criteria do need to be regularly revised, but it's a very small team working on these criteria. So if you do feel strongly the patient should be able to donate blood if you get the literature and good motivation. You can contact them directly. I think the other challenge with polycythemia, I think, medically speaking, it might need a little bit of a higher HB to maintain tissue oxygenation. So maybe
you want to get there.
You want to have a little bit.
Okay.
You want to.
Yeah, but I mean, obviously, we know that I'm not so sure about the quality of red cells actually in patient with polycythemia and also with the secondary hemochromatosis, where that's really the reason, whether the half-life of those red cells is going to be 3 months. As I said, there's something more related to that, and it's not really universally limited to South Africa, but probably to Europe and America too, that actually those patients are not a candidate for blood transfusion, especially those with secondary erythrocytosis or what they call or polycythemia. So I think maybe we should just look at it in more detail.
Hemochromatosis, the theoretical issue there is because that blood is rich in iron, it's a transfusion sepsis risk.
Yeah.
Because of the iron as a bacterial growth medium. So once you get the iron is down to low enough level, then it's considered safe for blood donation. The polycythemia, I would have to read that up. And
Also me too. I think it just awakened the devil in me.
Thank you.
And for everyone out there, please, the podcast is online. Please don't forget, log in. You can still catch it up. And yeah, what is it? What else do we have? Next week, because
it is a cost implication. Because if you are just polycythemic, then you go to the blood bank.
Oh God, people online. Guys, anybody online? We almost forgot on you.
Comments.
Any questions, comments, unhappiness, happiness? So we assume everybody's happy.
Thank you, Dan. All right, thank you, everyone.